All right, we're back. Welcome to I believe it's the ninth edition of the High Yield Rapid Pharmacology Review. This is Mike, and you'll be hearing me a little bit later. So, as always, just a little disclaimer, we do not include all of the information from your slides and such, so please don't just rely on us if you're crunched for time, by all means, but we're not sanctioned by the school and we don't have all of the information. So just take everything we say with a grain or maybe a mound of salt. So now that we're getting closer to D-Day, we'll have a little bit more questions throughout the presentation. So this one, we have a 65-year-old man who has smoked a pack of cigarettes per day for the past 40 years. Without reading any more, you already know, cancer. Presents to his physician with worsening chronic cough and increased shortness of breath for the past 2 weeks. He has lost 4.5 kilograms over the past month, complains of nausea, malaise, and for the past 72 hours, again, cancer. Denies vomiting or hemostasis. On examination, he is a well-developed man who intermittently coughs, producing yellow sputum. Other than mild tachypnea, his vital signs are unremarkable, and his pulmonary examination is significant only for diffuse, coarse breath sounds. An X-ray of his chest reveals a 3 to 4 centimeter perihilar mass, cancer, that was not seen in his most recent radiograph taken 9 months ago. So now, this is where we have to start worrying about second and third level questions. So clearly this guy has some sort of tumor, some sort of cancer, but now it becomes determining how can we figure out what kind of cancer it is. So labs, without giving you any specific clues like something is bolded, it's pretty clear if you look at it. The sodium is quite low. And if you look at his urinalysis, he is concentrating his urine because his osmolality is quite high, and he also has high specific gravity. So I'll give you guys a second. What type of lung cancer do you think he could have? And the way you figure that out is how do you differentiate between the lung cancers and the paraneoplastic syndromes that those lung cancers cause? We know this one is central, so most likely small cell or squamous. You guys got to remember that the only paraneoplastic syndrome that you'll be tested on for step 1 that is associated with squamous is peptide parathyroid hormone releasing peptide, so increasing vitamin D and calcium. So because we know this is not that, we're going to go with the assumption that this is small cell. Now, what's going on here and how are we going to treat it? So what is the following next best step for management of this problem? If you chose water restriction, you are correct. So what we're seeing here is SIADH, syndrome of inappropriate ADH excretion due to small cell carcinoma. I did not remember specifically. Don't think you're gonna. I didn't remember that. Obviously, I had to look it up. I forgot if it was small cell or squamous cell, but that's something that's going to be burned in your memory by the time you take the test, is the paraneoplastic syndromes and the lung cancers that they're associated with. Regardless, this is SIADH. We have an increase in our secretion of antidiuretic hormone, so we're not peeing, so we're concentrating our urine and retaining our water. Therefore, our sodium drops. And so it's like our sodium is low, but that's because we have too much water. And, it's showing hemodilution. And so to start off by treating that, the first thing we do is we restrict water intake. Sometimes the body can compensate for that and get to a point where it realizes it needs to start peeing out water. Fortunately, that doesn't always occur, and then we start going into some of the other agents that we can use to actually block the diuretic hormone receptor. So, sort of a little bit of a tangential question, but now we'll start talking about some of the calcium drugs. So first and foremost, are sort of the heavy hitters that you'll see quite a bit are the bisphosphonates. So we have oral agents, alendronate and resindronate. You'll see those quite a bit in your elderly female population. And then we have a few IV patients, zoledronic acid and ibandronate. Those more so treatment-resistant / unfortunately, cancer patients. Mechanism of action, they actually inhibit the osteoclasts. So by inhibiting the osteoclasts, you're inhibiting bone resorption. And remember, resorption is bone being broken down and calcium being released. Osteoblast build bone, osteoclast break it down. The way this works is it is a pyrophosphate analog, one of the constituents that goes into bone, binds to hydroxyapatite, and is incorporated into the bone. So when the osteoclasts are working and break this down, it actually is taken up by the osteoclast, and it kills it. So teaching points, it must be taken with water on an empty stomach. The drug in and of itself is very acidic, and if you don't take it on an empty stomach with water, there's a chance that it could get stuck in your esophagus, or it may cause a little bit of mucosal erosion. So extremely important. You wake up in the morning, within 2 hours before breakfast, you take this drug, and you must remain upright for 30 minutes after you administer it. It's like a huge teaching point. You can't lie back down. You have to take it and you have to sit for 30 minutes because of that risk, because the drug in and of itself is acidic. Uses, as I previously stated, first line in postmenopausal women with osteoporosis. It can also be used to prevent osteoporosis, Paget's disease of the bone, and also hypercalcemia associated with malignancy. Because usually you have mets to the bone, possibly causing an increase in calcium release. Side effects, as I previously stated with the administration tips, there's a lot of local irritation because it's so acidic. It can cause esophagitis, esophageal ulcers, and erosions. Upset stomach, heartburn, and gastritis. Therefore, big glass of water, empty stomach, get it going through. Big teaching point. 2 side effects you have to remember for the bisphosphonates. Every patient who will get put on one of these, when they're a little bit older, they'll need a dental exam if they have poor dentition, because you worry about osteonecrosis of the jaw. For whatever reason, some people have this predilection to having a breakdown of the bone in their jaw, and it can be catastrophic. So elderly patients with poor dentition will actually have to have a dentist sort of write a note saying they are comfortable with them getting the medication. The other one is, even though it can prevent femoral fractures in the elderly population, you're at more risk of atypical femoral fractures. Just sort of store that fact away. You're going to be putting patients who have had fractures before, non-traumatic fractures, you call that osteoporosis, and you're going to put them on a bisphosphonate. But, there's this odd risk of having, a non-stress related odd fracture. Lastly, for giving a drug to reduce the calcium levels, obviously can cause some hypocalcemia and hypophosphatemia. Next is sort of a tricky drug. It is denosumab. It's a rank L monoclonal antibody. So we use the picture to explain. So rank L is a hormone that's actually released by osteoblasts that goes onto osteoclast precursors and the osteoclast itself, and it's an activator. So if we inhibit this rank L hormone, we can inhibit the proliferation, differentiation, and maturation of these preosteoclasts. So indirectly inhibiting osteoclasts. Therefore, for osteoporosis in postmenopausal women, this is another drug that we can use. It's a little bit better in administration. You just get a subcutaneous injection every 6 months. Obviously, if we're lowering our ability to if we inhibit our ability to raise calcium, we could have some hypocalcemia. There's a possibility for infections because we're introducing a monoclonal antibody to the body, skin reactions, and osteonecrosis of the jaw as well. In patients who are extremely hypocalcemic, obviously we wouldn't give this drug. Next, we have our parathyroid hormone itself. So parathyroid hormone in and of itself is secreted when there is low extracellular calcium, it's stimulated, the secretion is stimulated by low extracellular calcium, which is monitored by a G-coupled protein receptor calcium sensor. So when parathyroid hormone is released, it induces osteoclast differentiation factor, so therefore it would increase osteoclast activity, so it would increase breakdown of the bone, and it would raise calcium, which is what we like it to do. In the renal physio, it will increase reabsorption of calcium and magnesium, and it also will increase the creation of a 1,2,5 vitamin D, another sort of component player in that vitamin D calcium physiology, which would have effects on the gastrointestinal system. Finally, this leads to an increase in calcium in our extracellular compartment on our Chem 10. So we use it for hypocalcemia, and we can also use it as an adjunct in hypoparathyroidism, not well controlled by just vitamin D or calcium supplementation. We can also use it as a challenge test for pseudohypoparathyroidism. Now, what gets tricky though is why we would use this drug for osteoporosis if we're trying to inhibit osteoclasts. Because everything I just told you was it's inducing osteoclasts to work. So we have two drugs, the actual human recombinant parathyroid hormone, and then we have teriparatide acetate, which is that. I don't know why she includes them in two different ways. Anyway, if we give it in a daily intermittent administration, we can actually increase the number and the activity of osteoblasts. So in women and men, women who are postmenopausal and men, we can give this to the patient population who are high risk for fracture. So I sort of just want to repeat that. Parathyroid hormone in and of itself induces osteoclast differentiation factor and can induce osteoclast activity. So it can increase bone breakdown to increase calcium. But when we use it for osteoporosis, what we're doing is we're giving it in an intermittent administration, and it's actually working to increase the activity of osteoblasts. So we're building bone. Very important differentiation point. This does not produce bone reabsorption. It increases the formation of new bone and will decrease fracture risk. Sort of, you got to keep the parathyroid hormone physiology and then the drug parathyroid hormone different. Black box warning, we have a risk of osteosarcoma. Obviously, if we're giving a drug that's going to increase the activity of the osteoblast, there's a risk of malignancy. Specifically in patients with previous malignancies, patients with Paget's disease, and patients with metabolic bone diseases. Therefore, we only use it for a max of 2 years. Don't worry so much about the fact that we only use it for a max of 2 years. I'd worry about, just understand if we're giving this drug, there's a possibility of osteosarcoma. Side effects are mild, nausea, dizziness, headache, some leg cramps, and orthostasis, and obviously hypercalcemia. Now, just a little background on vitamin D before we talk more about it. You have to know the different forms. Cholecalciferol is vitamin D3, which is what we actually get from, the sun, and then that is converted through our skin. Ergocalciferol is vitamin D2. This is actually, I don't know why I don't have it here on this chart. This is a bad chart. Regardless, vitamin D2, the most important form is calcitriol, or 1,25-dihydroxycalciferol. This is the form that we get after it's been converted into kidneys. So you always have to remember, you go, skin through the sun, liver to kidney. So this is the form that works, calcitriol. And therefore, if we have a patient who has chronic kidney disease, we're supplementing not with cholecalciferol, which is found commonly over the counter, but we're actually supplementing with 125 or even ergocalciferol. Now, On to calcitriol. So, as I said before, this is our steroid intranuclear hormone receptor. It's 1,25-dihydroxycholecalciferol. This is the active form. Patients are able to generate this. This will, as I stated previously when I was talking about some of the calcium homeostasis, this acting on our gastrointestinal system will increase intestinal calcium absorption if we're low. It will also stimulate osteoclastin, a bone matrix protein, and it also enhances calcium mobilization from the bone. So what do we use this for? We can use this for hypoparathyroidism, pseudohypoparathyroidism, osteoporosis, rickets and osteomalacia, and then finally the big thing is you want to use this for hypocalcemia and CKD, which is commonly known as secondary hypoparathyroidism, I believe. Correct me if I'm wrong. Adverse effects, hypervitamin D, hypervitaminosis D. So hypercalcemia. In this case, we need to withdraw the offending agent. Sometimes some people are taking extra vitamin D. We wouldn't want that. Treatment, just give fluids, a low calcium diet, and glucocorticoids. So remember, calcitriol, that's our 1,2,5 actual active form of vitamin D, which we're going to supplement in patients with hypoparathyroidism, pseudohypoparathyroidism, because they're not able to actually generate that PTH, parathyroid hormone, to eventually lead to raising our calcium levels. So we give them vitamin D because the parathyroid is going to have an influence on generating it. We can also give it for osteoporosis, but big point is calcitriol for hypocalcemia and chronic kidney disease. Now, you see the change in the color. We have calcitonin. Calcitonin is that hormone that, we learned in biology class. Calcitonin tones down the calcium. So this works through a G-coupled protein receptor, through cyclic AMP, or through adenylate cyclase to cyclic AMP. Now you may get a little mad at me for including that there. It's not so much important for the test you're going to take on right now, but for boards, don't get angry. But I'm sure you've seen for some of these steroid hormones and some of these receptors, they want you to know that it's associated with G-coupled protein, or it's a tyrosine kinase, or it's a nuclear receptor. And then they want to know, is it cyclic AMP or is it cyclic GMP? So we put them here just so you can start seeing some of those things. This is a peptide hormone, and we actually use the salmon-derived hormone because it's a lot more potent than the human preparation. So another reason why we hope that salmon don't go extinct, not just because they taste good, but because we need their calcitonin hormone. So this will inhibit osteoclast calcium mobilization. It increases renal excretion, and it increases phosphate excretion. It's only thought to really be physiologically significant under stressful conditions. So even though we talk about this balance between calcitonin and PTH, it's thought that it really isn't very significant. However, we'll use the salmon form because of its higher potency, and we can actually use it for severe hypercalcemia, osteoporosis, and Paget's disease. So in osteoporosis, it's only for those patients who cannot take bisphosphonates. We don't really like to give this drug. It's not really a first-line agent or second-line agent for that matter. Adverse effects include nausea, facial swelling, and a runny nose. The reason why you get a runny nose, and this is sort of a little bit of a tangential thing, is I believe one of the forms of administration is intranasally. It's like kind of like a Flonase or a Nafrin nasal spray. And so if you're using that form of the medication, you get a runny nose. Wouldn't really worry too much about the side effects, more so just the mechanism and how it's inhibiting osteoclast-mediated calcium mobilization, and it can be used for hypercalcemia. Those are sort of the take-home points. All right, So sort of just like a take-home osteoporosis. Calcium is important. Calcium is in milk, which is in cows. So there's the cow and the milk. In postmenopausal women, first line is going to be alendronate and risindronate. So those are our oral bisphosphonate agents. In severe disease, as you guys might have already learned, the DEXA scan, our way of determining how bad your osteoporosis is, if it's less than 3.5 standard deviations, age adjusted, that's when we get into the teriparatide or the PTH hormone analog. Premenopausal women, it's a little tricky. Usually we associate the loss of the estrogen hormone with causing, the previous thing was for postmenopausal women and men. In premenopausal women, it's a little different. Usually, if it's associated with amenorrhea, maybe there's some sort of primary amenorrhea cause, primary gonadal failure. We sort of try to go down that pathway and treating that pathway. Bisphosphonates long-term in premenopausal women, we don't really have a lot of efficacy and safety data. Some of the things we can use are teriparatide and sometimes SERMs. SERMs being those estrogen receptor modulators that I believe we haven't talked about yet. We might have already, but we might be talking about it next week. So just to take home, we should not be treating osteoporosis in menstruating women as they block estrogen in bone and lead to further bone loss. So we don't use these. And so it's a little tricky. We tend to not see osteoporosis in that age group in premenopausal women. So you don't really use bisphosphonates, SERMs are sort of out of the question, and sort of dig deeper for some sort of underlying cause. All right, and so just FYI for the boards, they'd like to ask about treatment of hypercalcemia, and they love to test about hyperkalemia. You got to know that for hyperkalemia, you give insulin, you give bicarb, and you give albuterol. Albuterol forces decay intracellularly, sodium bicarb does the same, and so does insulin. You give calcium just to stabilize cardiac membrane current. Calcium does not treat the hyperkalemia, it just stabilizes the patient. And then there are some intermediate long-term solutions. And then similarly with hypercalcemia, you tend to just give saline. You can give IV furosemide, you can give calcitonin, yada, yada, yada. Not for this test, but for the big one. This is important.